Dr. Debmalya Sanyal, he is working as a professor at Department of Endocrinology, KPS Medical College, Jadavpur, Kolkata. He got international travel grand winner for paper presentation at AACI. He is a reviewer of national and international journals. He is a secretary RSSDI, West Bengal chapter. He is also an executive committee member, Endocrine Society of Bengal. So I welcome sir. With this, sir will be sharing with us his expert opinion on topic gender affirmative hormonal intervention in transmasculine persons. So I welcome sir.
Good afternoon, and thank you for the kind invitation. Well, it's a pleasure to be here, and listening to the talks, especially the previous talk was really an eye-opener, and have been associated, especially as someone involved with this from the endocrine perspective, where there is a significant role with regards to treatment. Now, we have several guidelines. Ourselves, we are involved in one of the guidelines. One of the first guidelines which actually came up from India was the SAPHO guidelines, way back about 5-6 years back. And that took us almost a year, where we had psychiatrists, surgeons, ourselves, as well as people from the community as well as on board. And it was really a very important issue with regards to the first guidelines which we generated way back 5 years back. And subsequently we had publications a couple of years back with regards to male to female, which was published in Endocrine Society of India. And something which is very important is the fact that the population estimate, which is as per census 2011 is about 5 lakhs, is a gross understatement, especially if we take our population, and even if we extrapolate that to 2.5%, that ranges between 2.5 to 5% across the world. So that would be a gross understatement. So probably we are looking at a much bigger figure, and unfortunately only a minuscule part of this population actually comes to us for treatment or for evaluation. And we need to improve the comfort level, and that comfort level has to come not only from us also, but we need to build a whole clinic, hospital. The attitude has to change as well. It's not only the doctor which needs to change as well. We need to change and educate our staff, our receptionist, each one of them as well. And this is very important, something we need to look into. It needs to be done in a much wider perspective, and the awareness has to increase in a much wider perspective as well. So we are all aware with regards to criteria for affirmation, where we of course require the help of a mental health professional before they come to us, before we can actually help in any way with regards to management, because we require that so-called certification from the mental health professional before we can actually start our treatment journey. But of course, we also, as was mentioned previously, is that does that having a background, any psychiatric comorbidities, exclude the person? Of course not. Especially, we need to first exclude the fact that that is not the main cause for this issue, for the main concern. But very important, we need to realize that the endocrine management has to continue side by side if there is any psychiatric comorbidities as well. So it's not that those who are having any psychiatric comorbidities will be excluded from treatment. That is again something which we need to think about it. And again, with regards to using gender affirming surgery, 18 years of age is the age cutoff, which we also are handicapped. Some countries have the age of 16 years as well. So as we have learned that why do we need to treat, we have seen that the issues of depression, anxiety, suicidal ideation, not only suicidal ideation, but actually if you look at suicidal attempt is 25%. That is very important as well. And what is important is to realize that with treatment, there can be significant psychological benefit only with hormonal treatment. Before surgical management, only hormonal treatment, apart from inducing the physical changes, can have a significant impact on depression, on anxiety, on suicidal ideation, as well as quality of life and psychological functioning. So quality of life is a very big issue which has been emphasized by all bodies, and that can significantly improve as well. So this was one of our publications that was way back in 2016, when we had found that only nearly 11% had family support. Now we have revisited that quite recently, and thankfully we see that family support is now nearly 30 to 40%. So this is obviously, the society is changing for the better, something which also we must give credit to the increasing awareness as well. And what we had noticed was, which was very, very worrisome, was that a lot of surgeries had been done by unqualified people, and that was really dangerous, and these were quite disfiguring surgeries, unfortunately. And this is, so people were not coming over, and the knowledge that such facilities which can help was not there, and that's why they landed up with some medical intervention by unqualified persons as well. So this is something very important. Again, if we see there is a significant disparity between number of transmasculine versus transfeminine, though worldwide literature suggests that there is no difference in terms of incidence in transmasculine versus transfeminine, but obviously because of our bias, male bias in our society, which is still so much there, so obviously the male are more privileged, so they are more, society is more acceptable with regards to their concern. And that's why we have seen that about 60 to 70% were actually transfeminine, from male to female, versus only 30 to 40% transmasculine, that is female to male, because obviously the acceptance of a female coming out in the open was much less in the society. So that is something which was there, but that is again changing, which when we see in our practice nowadays, even in the last 10 years, there is this gradual shift, and this gap between transmasculine and transfeminine seeking our care has been coming down as well. So very important again to emphasize is the fact that we need to have individualized care. The care has to be actually catered to the person's concern. We have had persons who don't want a binary identity. So there we have to appreciate. Some people don't want to do surgery, so we must appreciate that as well. Some people don't want significant changes, they want subtle changes. So we also need to tailor our treatment according to that concern. So that's very important. That is individualization of therapy. There is no cutout therapy that this is the minimum thing we need to be doing. That is very important. But obviously, before we embark on that, we need to identify and evaluate underlying medical conditions as well, which may be worsened by hormonal intervention as well. Something we need to be careful, because this is important for the physical health as well. Discuss fertility perspective prior to embarking. Actually, that has to be discussed by the mental health professional prior to coming to us with regards to endocrine intervention. We must also be upfront with regards to limitations of medication as well, and the expectations. You know, the expectations are in most of the patients, it's quite most of the person, it's quite big expectations. So we need to be upfront with regards to limitations of therapies as well, and that has to be conveyed as well. And very, very important, after surgery, a huge amount of people don't come back to us, but this is surgery is just an intervention. This is long-term therapy, which is very essential, not only to preserve physical changes and mental changes and quality of life, but also for health benefits, whether it is cardiovascular benefit, bone benefit. So this is very important. So this has to be emphasized as well, that after surgery, we need to again come back for the endocrine management. So lot of them are lost to follow up. So that is an area of improvement which is required. And we require regular monitoring, not only for effectiveness of therapy, but also for side effects as well. So goals have to be individualized, and it is also unethical to deny medication even in patients who have hepatitis B, C or any other infections as well. And again, we also ourselves have a debate whether the lab values or the tests which we are doing, where we need to compare with cis, with native gender or the adopted gender. This is very important to emphasize as well. But thankfully for us, satisfaction rate with endocrine treatment is nearly 90%, and regret rate is less than 1.5%. So this is again very important. The treatment is mostly successful, and here lies the crux of the management. So the awareness is lacking, that people think there is no treatment, there is no avenue. That has to go, and that needs to be emphasized as well. So we have different categories of patients, people coming with regards to patients who have not done any surgery or any hormone therapy, but also, as I have mentioned, people coming with prior surgery already done, especially from non-medical persons, which is a difficult issue. Again, there is an issue with regards to children, as well as the opposite side of the spectrum. Adults, I've had people coming in to see me for diabetes, and then I've seen that they have been operated 60 years along with their daughter, who is also there but not been treated, having been operated. So this is something which is very, that puts them at a significant health risk as well. So this is very important. Again, illicit drug use, because of people not getting access to healthcare, especially in towns or small villages. So that is also very important. So there we need to go for bridging therapy. We need to assess whatever treatment and whatever harm has been done, and restart medication as well. So this is very important. Bridging is something which is often overlooked as well. And though it is more common with trans female, after gonadectomy, lot of them come over to us with regards to coming first time to us for medication after gonadectomy, but it is much less with the area which I am going to concentrate today, which has been allotted to me, that is transmasculine, that is much less. So baseline investigations with special emphasis on complete blood count and biochemistry and renal and liver function tests. The minimum test has to be done. It's not very expensive as well, and follow-up is necessary. So this baseline investigation prior to starting treatment is also very, very important. Now, with regards to transmasculine, testosterone therapy is basically standard of care, and thankfully for most that is adequate to not only suppress the endogenous hormones, but also adequate to change, adequate for physical change as well. Unlike trans feminine, where you have to have additional anti-androgens to suppress the endogenous hormone. So that's very important. And so in transmasculine, the options especially can be intramuscular, which is the commonest method which is used to intramuscular injections. Now the same some of these intramuscular injections can be given subcutaneously. Now the problem with intramuscular injection is, one is you have to go to somebody to give that injection, and again it's much more painful, and also the access becomes difficult as well. So this is much easier because subcutaneous insulin is just like subcutaneous injections is just like insulin which you can take on your own. Transdermal is more expensive in our population. That is a problem. And transdermal patches are not appropriate because of the humidity which we have in most of our countries. And very important is the fact that the initial complications, the polycythemia, which can rarely occur with testosterone therapy, occurs early on, especially within the first 3 to 6 months and more in the first 1 year. So there is, an urgency which we appreciate with regards to change. But if it is hurried on, then what happens is this complication risk increases. So we need to start low and gradually build up the dose, and then that's safer as well. And once an appropriate change has been done, we can again cut back on the dose, especially with age as well. And there are some monitoring, especially with regards to blood count, especially hemoglobin and hematocrit, which can go up with testosterone therapy. The liver transaminitis is no longer a major concern. It has been removed from monitoring, regular routine monitoring in transmasculine people. Lipid profile, because lipids can adversely affect cardiovascular disease like myocardial infarction, heart attack and stroke. So that has to be monitored. Again, glucose is most important with regards to trans feminine rather than transmasculine. So it has been found that there is not much intervention with blood glucose level with regards to testosterone therapy. Bone mineral density, again osteoporosis and fracture remains a very important concern, especially after operation, after gonad removal. If lot of people don't come back, and then there is a risk of osteoporosis and fracture. So that is very important. In those patients, osteoporosis has to be evaluated as well. So what are the absolute contraindications, or if a person is already on hormone therapy, where you need to stop? One is pregnancy, which can rarely occur because, again, testosterone therapy, mind you, is not a guarantee for contraception. So this is very important message. So one can have, and we have seen accidental pregnancy, and if that is detected and if it wants to be continued, then we need to stop immediately. That is one area where it has to be stopped. Unstable cardiac disease, including coronary artery disease or heart failure, and also the hemoglobin and especially the hematocrit going beyond 55%. And very importantly, if there is a hormone sensitive cancer like breast cancer, then also it has to be stopped. One important aspect which is very commonly neglected is, we have people, especially on the obese side, who have obstructive sleep apnea. So this is something we need to inquire, especially nighttime, daytime somnolence, snoring. This history is very important because that may lead to obstructive sleep apnea, and this is a relative contraindication of testosterone therapy. So something we need to be aware of with regards to contraindications and where we need to stop and evaluate and restart once it is corrected. Again, the hormonal regimens, as we have discussed, can be 3-monthly injections of testosterone, or weekly or even twice weekly injections, or the gels. One of the concerns with gels is that it can be transmitted to the partner. There can be skin irritation, and it is of course very costly. But if there is a complication, especially metabolic complications and polycythemia, gels may be a safer option. Again, targets with regards to hormonal targets in the male range, normal cis male range, is better reached with injection therapy than transdermal therapy. Again, menstruation is better suppressed by injection than transdermal therapy. And also with subcutaneous therapy, now the data is coming up with subcutaneous therapy, and a lot of my patients are very comfortable. A lot of my persons who masculine are very comfortable with subcutaneous injections because they don't have to go to a place to get their shots. That's very important as well. And very importantly, the fluctuations in the hormonal level is significantly less with subcutaneous therapy as well. These are the host of injectables which are available. Not only that, we have the testosterone undecanoate, which can be given 3 monthly, which is also available, but it is very important when we are using testosterone undecanoate, it has to be taught very well how it has to be used, and it has a small risk of pulmonary embolism, oil embolism. So that is something we need to be monitored as well. So a lot of people are taking testosterone undecanoate, some of them without adequate monitoring. Again, gels are also available in our population as well. Now this is, there are 2 publications with regards to subcutaneous injection, and what was found was that they were well tolerated, effective, and reached their target testosterone level and induced similar changes, but they had much less significant serious side effects. So it may be a safer alternative. Again, another study showed that lot of people actually preferred, at least then they shifted from intramuscular to subcutaneous testosterone therapy because of ease of therapy, because the problem was that we need to have, there is a significant discomfort and pain with intramuscular injection, and not only that, it also requires arrangements to be made and administered by somebody else. You cannot have intramuscular injections self-injected. So subcutaneous injection, especially subcutaneous testosterone, is a new avenue of treatment, and that is better accepted by and preferred by a lot of patients as well. So we had another publications where 61% of patients were actually on testosterone injectable, 11% actually required additional GnRH initially to suppress menstruation, and also about 22% were on medroxyprogesterone as well. Now, testosterone undecanoate are preferred by some because you are injecting every 3 monthly. It's easier rather than every 2 weeks or every 3 weeks. So it's much easier, but it's more costly. So only 20% prefer that. Because of cost limitation, about 70% prefer 2 weekly or 3 weekly injections, which is more affordable. Again, for similar reasons, gels are not preferred. Again, surgery has, we found, was done in about 50% with mastectomy, and about 30% had TH-BSO. Again, prior mastectomy, again an area of concern, was done in nearly 17% without following protocol by people who were unqualified. Again, this is an area of important concern which we need to address as well. So we need to counsel with regards to the fact that most of the changes take some time. Like normal puberty, it takes about 3 to 6 months to kick in, and most of the changes are acquired by about 2 to 3 years as well. But there is no randomized trial to say that which hormone regime is superior. Very importantly, facial body hair and muscle strength may not be adequately changed with injectable testosterone or hormonal therapy. That is something we must remember as well. And very important, voice may not be reversible as well, something very important. So the effects are set in much late when it comes to change in hair, change in muscle strength, compared to other factors like with regards to cessation of menstrual cycles or periods occurs much earlier. Now, one very, very important concern in transmasculine is stopping of menstrual bleeding. Most of the time, this can occur within 3 to 6 months by using testosterone therapy alone. But in some population, some persons, this may not occur, so we require additional therapies like GnRH, which is more costly, but medroxyprogesterone. But very important, prior to that, we need to see whether adequate testosterone levels has been achieved or not. Because for most of them, if we achieve adequate dosage, then the cycles can be stopped. Similarly, if the patient is on transdermal preparation, then we need to shift to the more effective injectable. But again, we should also emphasize the fact that excessive higher dose, supraphysiological dose, which is very commonly used in that should not be done. That should be strongly advised that we should not go ahead, that the patients, you know, sometimes from themselves go ahead with supraphysiological doses, which is not advocated. Again, duration, this can be continued lifelong, especially with regards to testosterone therapy, can be continued lifelong unless there is an emerging adverse effect or contraindication. Very importantly, as with aging, the dose has to be adjusted and probably lowered and tapered down, and we can go for safer options like transdermal testosterone, which is a much safer option. But always, especially with age, we need to keep an eye on monitoring as well. So there are targets of therapy, which is between two injections, especially the injectable, the trough level has to be in the male range. When we are taking the 3-monthly injection, again we monitor just before the next injection. When we are routinely monitoring enanthet, which is taken every 2 to 3 weeks, we can also monitor midway between injections. Especially with regards to, this is with regards to how you monitor when we are taking testosterone therapy, and especially when it is subcutaneous, the transdermal gel, it has to be monitored at least after a week's application as well. And monitoring apart from testosterone, estradiol doesn't require regular monitoring, is very important monitoring for hemoglobin and hematocrit and lipid profile, because that can cause excessive hematocrit, can cause blood clotting, venous thromboembolism, stroke as well. So this is very important. Hemoglobin, especially in the first year, 3-monthly monitoring of lipids and for hemoglobin and hematocrit is essential, as well as hormonal evaluation. After that, it can be done once or twice yearly as well. Routine screening for BMD for osteoporosis and bone health is not recommended. It is generally done if there are risk factors as well. So the medical risk which can occur once we start testosterone therapy can be dyslipidemia, hypertension, osteoporosis, as well as some risk of cancer. But very, very important is the fact that with regards to erythrocytosis, that is the commonest thing which is seen. Acne, erythrocytosis are the commonest complications which are encountered, and this is actually associated with tobacco use, longer acting injections, as well as with obesity, and also chest conditions like COPD and asthma, where it is associated with erythrocytosis. So very important lifestyle modification. First is quitting of smoking. That is whether in male, transmasculine or feminine, it is very important to quit smoking, because the risk of thromboembolism is there for both if smoking is continued. So that is very important as well. And because of stress factors, this is probably more common in transmasculine and transfeminine. So quitting of smoking, maintenance of body weight is also very essential, because that is associated with increased risk of erythrocytosis as well. And this is more commonly seen within the first year of therapy, especially within the first 3 months of therapy as well. And so there what we need to do is we need to cut back on the dosage, or may require to stop testosterone temporarily and probably go for safer options. There is this stop bank questionnaire which actually is used to assess obstructive sleep apnea, and especially new onset obstructive sleep apnea is a contraindication for starting testosterone therapy. Very important, the lean body mass, the muscle mass of transmasculine is in between cis male and cis female. There is some worsening of cholesterol and triglyceride level and lowering of good cholesterol with testosterone therapy, but thankfully in terms of ischemic heart disease, cerebrovascular disease, there is no impact in short term as well as in middle term up to 10 years with testosterone therapy. A recent publication was there which showed that up to 10 years, we are looking at data beyond 10 years, it's safe in terms of cardiovascular perspective. And again, this is the study which I was talking about, the European Network for Investigation of Gender Incongruence, the ENIGI, which looked at long-term effects of hormonal therapy. And in transmasculine, the commonest side effects were acne, erythrocytosis and dyslipidemia, but it was found to be generally safe in terms of mortality and cardiovascular event in the middle and short term up to 10 years. Now they are looking into long-term cancer risk as well as cardiovascular risk beyond 10 years as well. So this is very important study to look out for. Now with regards to long-term use, especially with aging, to decrease risk of cardiovascular events, we require to decrease dose and look for safer alternatives like transdermal preparation. Very important is regular follow-up with regards to blood pressure, body weight and lipids, and assess cardiovascular risk. If there is cardiovascular risk is coming in, we need to treat appropriately, just like what is done in guidelines with cardiovascular risk as well. Pre and post-operatively, generally with transmasculine, there is no need for stopping testosterone therapy. A lot of people come that we need to stop testosterone prior to surgery. It's not required for most unless there is cardiovascular risk or polycythemia. We don't require to need to stop testosterone therapy prior to surgery. But very important, testosterone has to be restarted post-operatively. That is very important because a lot of people, especially after bottom surgery, do not restart testosterone. That can be really harmful if there is no endocrine treatment post-operatively. With regards to cancer, generally the cancer monitoring is similar to whatever organ is there, especially if it is breast. If it is not removed, operated, then we need to follow as per female guidelines with mammography. If it is operated, it has to be subareolar and periareolar inspection and investigation with regards to any breast malignancy. Again, routine screening for cervical cancer is, and endometrial and ovarian cancer is only required if these organs are not removed. So again, very important. With regards to bone health, routine screening, the testosterone therapy takes care of the bone. So very important for bone health, we need to continue testosterone therapy. But if there is discontinuation of testosterone therapy, then we need to reassess, or if there are risk factors like personal history of fracture or a very strong family history of fracture, then also we need to assess the bone mineral density and for osteoporosis. For children, we have already talked about pubertal blockade with GnRH till the age appropriate level when we reach, when the children can take a decision as an adult with regards to starting gender affirming hormone therapy. With regards to pubertal induction, when we start pubertal induction, especially in transmasculine, the testosterone dose is much lower, 25 milligram, and over 6 months, gradually we increase the dose after every 6 monthly to reach the adult range. Whereas in adults, when we are starting therapy, we start at a much higher dose, almost 50% of the normal dose, and over the next 3 to 6 months we reach the adult dose as well. Talking about fertility prevention, again we need to counsel about contraception, and with regards to oocyte preservation, a discussion has to be made as well. So in summary, we have to follow a stepwise protocol with a multidisciplinary team, which includes the mental health professional, which includes the surgeon as well. We need to check for eligibility, we need to monitor for adverse effects as well as prior to treatment as well, any risk factors as well. And we need to inform the adverse effects, the irreversible changes, and very importantly, we need to explain the timeline of changes. Otherwise, there can be significantly higher increased risk of depression because of the expectations are not met as well. Prior counseling with regards to fertility is very important. With regards to testosterone therapy, the physical effects gradually come in within 3 months up to 2 to 3 years, which is very, very effective in maintaining the physical changes. We can continue and should be continuing lifelong unless there is an obvious contraindication. Not only there is improvement in physical attributes, but also there is improvement, very importantly, in quality of life, in psychological functioning, decrease in depression and suicidal ideation, which was just highlighted very well by my previous speaker. So that is the very important impact of hormonal therapy, and that has to be continued even after surgery as well. And but that the doses may have to be reduced after surgery, especially with long-term treatment. Now, hormone therapy with testosterone again has been found to be very safe, at least in terms of middle and short term, over a period of 10 years, both in terms of cardiovascular and cancer risk, but still long-term data is awaited. But we need to really explain that the prescribed doses has to be adhered to. Lot of times supraphysiological doses are used, which has to be strongly discouraged as well. And very importantly, there has to be an adequate endocrine follow-up. We need to monitor for side effects, and especially those who undergo surgery, testosterone can be continued, but those who do not undergo surgery, we need to monitor for cervical and breast cancer risk as well. So with adequate monitoring, adequate follow-up and regular treatment, the outcomes are very good and encouraging, and we are looking forward to long-term data as well. Thank you very much, and thank you for a patient hearing.
Thank you, sir, for addressing our group on different treatment modalities which is used in transmasculine persons. Now, I request Bindu ma'am kindly come and felicitate our speaker. Do you have any query? Yes. Sir.
So first of all, I'm a trans man myself, so I think I take this privilege to be here, and the kind of knowledge and information that you share was much needed. I know most of the people would not grasp it, but because I've been through it personally, I can get every word of what you said. We need more doctors like you, sir, who can talk about this very openly, because the amount of medical risk that you openly share are not shared by, so I also run a charity for transgender, gender-affirming surgeries. So I have people and applicants coming to me as well, mentioning that the HRT, first of all, is very expensive, and that our charity could help them with the right treatment and sponsor them for the HRT. Alongside, most of the medications that are now available, globally, are not accessible in India. So the results that they are expecting out of it has been not put across well. So they go for a rush into the surgery process because they cannot see the results as they were expecting through the social media post, right? Because too much information out there on the social media is also dangerous. So it's always good as a trans man for me to tell that we need the right doctors like you to approach, get the right information from the professionals is much needed at this point. If people are listening to this on the YouTube video, I would want people to reach out professional. So my question to you is, one is there anything that we can do to make, like as a team of endocrinologists that you would be having globally or in India, is there somewhere first we can get those medicines to India, okay? Because testosterone and testosterone, which a trans man do take, right? Do also have the adverse effect, as you mentioned. I have a lot of bone issues, okay? And frankly, I know every risk that you mention, I am on the peak of it. But stress comes with it, and I am also addicted to smoking. Everything done and said, sir. One is we need some action plans from the endocrinologist part as well, where there is also a list of transgender people that this is gender affirmative clinic where you can reach out to and you can be open about discussion yourself. Because let me share just one of my experience, because when I'm 34 now, so 17 years back when I started my HRT, hormone replacement, I was not well guided about it, and back then the information also everywhere was very low. You can't actually get anything. So at the age of 19 I was put on adult diapers because I lost my urethra control. So because I started endocrinologist at the age without understanding the doses, the amount that I was supposed to take and the risk factors, it is really traumatizing that I'm already under gender dysphoria and the part that I was going through, and then to be wearing adult diapers at the age of 19. So that is also something that more people like you should talk about, what could be the adverse effect of the HRT. And HRT today is a choice, which is excellent. It's not a mandatory for person to go to HRT. For the ones that want to, I really want to help with the HRT treatment, but I can't because the right infrastructure for me to tell, okay, go to this doctor is not available. So is there a list or a panel of doctors where we can refer people to? That's my question.
So one is, first of all, there are lots of, now encouragingly, lots of people, endocrinologists, who are actually looking into gender affirming hormone treatment. So, and it's available across India as well. So that there are a lot of, you can look up now internet, and probably we can work it out with the endocrine society with regards to those who are interested in gender affirming care.
I'm sorry, there has been seen a monopoly in doctors as well. So if I go to an HRT doctor for an endocrinologist, he will have a tie-up done with one of the surgeons inside, which may not be fruitful for the patient himself, but it has been an exchange of monetary gains, and that is why the concern is right person. So I can't rely on social media completely at this point.
So again, you know, there is a lot of things which are circulating in the social media, where we have to we see, especially with regards to treatment, people coming very late to us, discontinuing therapy, having lots of fears in the background with regards to treatment. One is, as we have shown out here, mostly up to 10 years now we have data in terms of cancer and cardiovascular risk. It is safe. This is the European data we have, and I would like to tell you, almost all medications which are available abroad are available in our country. That is one thing. So there might be some medications which are more costlier, like testosterone undecanoate or gels. So, but it's all available. But even the routine testosterone injections are cheap, and what is used abroad is almost similar. So most people can afford it if they are well informed and they are safe. Now with regards to safety, an important issue is lot of people are ill advised with regards to their earnest desire to reach their goals to excessively medicate them. So the doses have to be appropriate rather than supraphysiological dose. People land up with problems mainly because they use supraphysiological or excessive dose. They have to stick to the regular monitored dose which is recommended by the doctor, by the endocrinologist. So that is very, very important. So one should not ask their peer, and so you are taking this dose, so you have got benefit with this dose, so I am also going to take this dose to get that similar benefit. And that's why I can get my benefit rather than in 2 years, because as our puberty occurs over a period of 3 to 4 years. So how can the changes be made overnight or in 6 months to 1 year? It's not possible. It's not natural. So you have to give that time. So rather than, some people are ill-advised and take supraphysiological doses. That has to be strongly discouraged. And also illicit medications, because the legal and official medications are all available. There are a lot of endocrinologists who are practicing as well. And also with regards to, personally, I tell my patients that you look up in the internet. There is now a whole lot of information with regards to who practices, who is a good surgeon across India, and you choose your doctor with regards to surgery. So there might be a few people which is there in every profession, but I think that's a minority, that's not majority. So that is, so they should have the liberty to choose the surgeon they want to go. So that's a separate discussion, but very important is that the issue is that after surgery, most people don't come back. They think that's the end, they have achieved the end goal. That is not the end goal, because if medication is not followed, they will become hypogonadism, which increases the risk of osteoporosis. The fracture, osteoporotic fracture, doesn't occur because of testosterone therapy. It occurs because of no hormone therapy, no testosterone therapy, no estrogen therapy. Yes. So that misconception has to go. Yes. The cardiovascular risk also increases significantly, and the psychological risk also increases because the quality of life worsens. So it is imperative to continue medication. At least testosterone can be continued lifelong with monitoring and dose adjustment.
Sure. Thank you, sir. I agree on everything that you said, and definitely I want people, trans-masculine or trans women, to go see a professionals over sharing their, peer-friendly advices, because this is something you're trying to put inside your body, which is going to have an impact for a lifetime. So thank you again, and I hope to talk to you outside, so maybe get some more knowledge out from you.
And always, please advise everybody, this is not for, it is for every one of us to quit smoking, to maintain a healthy lifestyle, and to reduce body weight, because it benefits everybody.
Yes, sir, I'm on therapy. I might get out of it too soon. So thank you so much.
Thank you.
Thank you, sir, and thank you all the participants. Now I request Bindu Shaju ma'am for the felicitation of our speaker.